All right, good afternoon, everyone, and thank you for joining us today for our webinar on market trends. Specifically, the three topics we'll be discussing will be reference-based pricing, pharmacy benefit management, and leave administration. My name is Chris Marin, and I'm with Hampton Consulting. Just a couple of slides here at the beginning to give you a little background on our firm. I'm going to really start by just indicating what we are not. We're not a broker that spreadsheets existing carrier grids and canned solutions for employers. We are not what we refer to as a 90-day partner, somebody who's just going to be working with you with a flurry of activity right in advance of your renewal. We're looking to partner with our clients throughout the year and help them managing their comprehensive benefit programs. We're not a firm focused on amassing volume with a particular carrier and, padding our pockets through overrides. We are not a company focused only on our bottom line. We're really looking, as I said, to be financial stewards of our clients' investments in their group benefit plans. What we are, privately held independent solution provider in the group benefits marketplace, seeking to understand and then help our clients solve their challenges. We're a team with varied backgrounds in underwriting, product development, administration, plan design, vendor management, so forth. We're a firm implementing both traditional and industry challenging solutions. So again, we're trying to not only be experts in self-funding and more traditional approaches, but also being aware and keeping our clients informed of new solutions coming to the marketplace. We're a partner. We're taking really a three-pronged approach to all of our client engagements. And those are risk management, data management, and health and welfare compliance. So today's topics, again, we'll be touching on reference-based pricing, a little bit of background on the solution and how the programs work, pharmacy benefit management, and then outsourced administration. So starting with reference-based pricing, it is no doubt a unique approach to the cost challenge. It is in many ways a complete shift from some of the traditional delivery methods and ways of providing group benefits, group medical benefits for your employee populations. So a slide here, just a little history, nothing new to any of us, I'm sure, but just a history here showing the changes in health insurance premiums relative to workers' earnings over a roughly 20-year period. And just reading an article recently, I believe on a PEPM basis in 2020, the cost is projected to be $12,000 annually for medical coverage for group benefits, group medical. So again, certainly those numbers would vary whether it's single coverage or family coverage, but the average is $12,000. So if you're looking to budget, that's a figure you can look to use in 2020. Certainly, the trend increases that we've seen have decreased somewhat in recent years, but it's still a key issue for employers looking to really get their arms around this spend and the effective ways to manage the cost. So what are the drivers? Really, increased utilization, aging population, technological advancements, special meds. We've seen all of these before as the justifications for the increases in cost year over year and in the renewals. While you can certainly address these individual issues and have an impact on your spend, but reference-based pricing is really looking to get to a bigger issue, what they believe to be the real driver, and that's the cost of the actual services. So this next slide here just really outlines what hospitals are charging for some common items. And I think we've all seen exhibits like this in the past, read articles, but the markup is really just unbelievable. When you look at the retail cost of something, and even if you've gotten an EOB yourself, if you had an inpatient stay, and you get one of the bills and you start to see the itemized costs of everything. I mean, 1,000% markup, 2,600% markup. It's really unbelievable. And where are these prices listed? Well, they're not listed anywhere that you and I are going to see them. They're located on the charge master, which is something that facilities maintain, and it really references the cost of the services that they are basically going to be billing. They're marked up costs that they then negotiate pricing with providers from this point. So it's not really even the true cost that the insurance company is coming in and getting a discount with there. It's a significantly marked up price, and that's really their starting point for the discount. This next slide is just really showing you some of the regional and national percentage markups by state. And again, this is based off of their average markup from Medicare. So again, you can see here in Pennsylvania, 412%. New Jersey, I think, is at 580, just under 600%. So significant markup when you're looking at what the Medicare reimbursement of these services would be. So as a result, there have been efforts made in recent months, and actually this is a result of the Affordable Care Act, but CMS was requiring hospitals to publish their costs for various services. But the challenge with this, as we highlight down here below, is that the pricing information provided is of what a procedure costs is going to be on average before insurance. So nowhere near what you may actually be charged or end up paying for that particular service. So again, so the number that they're starting with there is that 3,000% markup acetaminophen, or 600% markup knee replacement, whatever the service may be. So what reference-based pricing is looking to do is really provide a complete shift in the determination of the costs, and it's referring to it here as this bottom-up versus the top-down approach. So in a reference-based pricing scenario, the partner that you're working with, the reference-based pricing firm, would be starting at either Medicare reimbursement or the cost, which is the self-reported all-in cost from the hospital, which they basically publish each year and keep record of, similar to the charge master. So again, it's that pricing for the services before it's had that markup. And with reference-based pricing, there's really no network. So that's the other huge departure from traditional delivery models. You're not tapping into a network. You really have the ability to go to any facility, utilize any facility, and then the reference-based pricing firm is going to be negotiating directly with that provider for the cost of services. So some key points to consider when you're evaluating reference-based pricing partners and a solution is the reference-based pricing firm going to be a co-fiduciary with you? Are they going to truly be in the trenches with you when they're negotiating and having your best interests in mind when it comes to the cost of the services that they're negotiating and the negotiations that they're doing on your behalf? Legal defense. Do they have a legal defense? Because there is a component. If there's pushback from the facility, they have to have the ability to negotiate, and the ERISA attorneys on staff play a key role if that ever is the issue. The partners that they're working with, from both an administration perspective, so the TPAs that they're working with, are they familiar with reference-based pricing, how the programs work, the stop-loss vendors that they have in place? Are they familiar with the model and the approach? And it's important as well that there's synergy between those two. The claims need to be processed on a timely manner, and the communications with the providers need to happen quickly, just to make sure that things continue to flow through the system and there aren't any delays in regard to payments and reimbursements. And then member advocacy. Certainly, employees are going to have a lot of questions. There's a significant education that needs to take place up front with the employee population, and you want to be dealing with somebody that has experience. So in other words, they haven't just decided to get into this arena. They've been performing reference-based pricing for a number of years. So here it's just a summary of a recent analysis that we had done for a group, about 230 employees in the central part of Pennsylvania. The premium we have listed there, so basically that's their all-in cost. So that's basically what they're paying from a perspective of their admin fees. Or excuse me, this particular group was insured. I apologize. They were insured. The stop-loss deductible that we have listed there, that's actually the pooling point that they had in their insured contract. So we have it referenced here as a deductible, which is what it would be if they were self-funded, but that was really the pooling point that they had in their insured plan. 230 employees, and you see the spread here of enrollment, a little bit heavier enrollment for single coverage, which is not at all uncommon. So after evaluating the claims for this group, ELAP had come back to us. We were working with ELAP in this particular situation, and they came back with a estimated savings of just under 24%. So you see on the low side, the worst case scenario, they were anticipating a 10% savings. Best case, be up around 38%. But based on their experience and the number of years that they've been in this, looking at their book of business and evaluating the claims against similar employers, they felt very strongly that they could be saving 24% by moving to the reference-based pricing solution. So again, it's a fairly complex process when we consider it against the traditional delivery methods and the ways that benefits groups have provided group medical benefits, but it also has the ability to provide some significant savings. So moving on to our next topic today, which is pharmacy benefit management. A little bit about PBMs first, I guess, for anyone who may not be familiar with the acronym PBM. It's a pharmacy benefit manager organization that helps employers really do the various things you see listed here. One of the most important probably is maintaining the pharmacy networks and helping you with the establishing the formularies and administering those formularies. Certainly also negotiating pricing, and they help you to contain the overall cost of your prescription programs, which are the highest rising aspect of group medical plans, roughly anticipating 30% increases or so year over year. So the role of PBMs, what are they doing? They're helping you to reduce spend by negotiating price and implementing clinical programs and supporting the consulting effort in regards to your prescription drug benefit plans. They're increasing access to medications by negotiating prices and facilitating delivery, and then providing access to their large retail networks. So they really have it noted here at the bottom, really the connectors between employers, members, the wholesalers, the pharmacies, and the drug companies. They kind of are that common contact point for all. The ways that they help plan sponsors save money, as we mentioned, are negotiating discounts, helping to promote increased use of generics, making the distribution of the medications more efficient, so whether that's through mail order or other means, negotiating rebates, and then overall formulary management. So that's basically the management of the different medications out there in the marketplace and which tier they may be falling into based on that group's formulary. So the discounts, PBMs generally leverage their market share to negotiate better discounts than an employer or plan sponsor could if they were going out individually on their own. The brand discount is going to be a guaranteed contracted discount on brand name medications negotiated with both the retail and the mail order pharmacies. And then a generic discount is guaranteed contracted discounts on generic medications. Guarantees are achieved through what they refer to as MAC pricing, maximum allowable cost, where there is a determinant, there's a point established that's the maximum allowable cost that could be charged for a particular medication. It's the maximum amount, as we said, a plan will pay for generic drugs and brand name drugs that have generic versions available. These lists vary by pharmacy benefit manager. Not all generics are going to have a maximum allowable charge, and MAC guarantees range from 30 to 60%. Rebates are another way that pharmacy benefit managers help employers save money and manage their drug spend. Rebates are basically, it's a refund that's received from the drug manufacturers for the inclusion of their products on a formulary, or a payment from the manufacturer directly to offset the cost of that particular drug. They're negotiated with plan sponsors in a number of ways. They can be a guaranteed fixed dollar amount for all claims. They could be a percentage or fixed amount for all brand claims. They could be a percentage or fixed amount for all claims that are listed on the formulary, or they can be a percentage or fixed amount based on all claims that are able to be rebated, so specific to those drugs that have a rebate available. So some things to consider when you're shopping for a PBM. Generally, the services provided are to aid in the reduction of overall medical costs. These are the clinical programs is what we're talking about here. I apologize. Clinical programs that the pharmacy benefit manager would help you implement. They're not included in standard administrative pricing. Generally, there's a PEPM that's charged depending upon the program that you're looking to implement. We have some of the examples of them listed on the slide here: disease state management, quantity limitations, step therapy, very common, prior authorization as well for certain medications. So these programs, when implemented, can help you to really rein in costs based on the utilization of your particular population. Reporting as well. Pharmacy benefit managers should provide regular reporting to the plan sponsor. Standard reports are usually included in the contract, and then ad hoc reporting is available upon request, or sometimes there's a separate platform that you're able to access and perform your own ad hoc reporting. So from PBM selection overall, what are the things to consider? Number of items we have them listed here: the dispensing fees, if any, that they may have, or are they just charging an administrative fee? Rebates, how are they basically splitting them up? Are they holding any of the rebate? Is it 100% pass-through? What levels are the rebates at? What clinical programs do they offer? As you mentioned, reporting capabilities. So there's really a number of points to consider when you're evaluating the marketplace and various PBMs out there. In this slide, we have a sample comparison that was done for one of our clients not too long ago, and you can just see the amount of detail here in terms of the information that we're looking to address and compare when evaluating one vendor versus the other. In this scenario, the group was with Highmark, and we also had some proposals from CVS Caremark, Optum, and Express Scripts. And in this particular scenario, again, similarly sized employer, I think this was one around 230 or so employees, 211 employees, there we go. The marketing in this case ended up showing that there was about a $65,000 savings that could be achieved with Express Scripts. Again, these are savings estimates because really what they're doing is taking the claims experience for a group from the most recent 12-month period and then running that through various pricing scenarios. So assuming that the exact same utilization took place, this is the apples to apples comparison. It's sort of saying if you were in this particular model at that time, this is what it would have cost you. So the savings are projected. And our final topic today is going to be absence and leave management. So one of the reasons why employers are looking to really take advantage of some partners who they can outsource the leave management to is because it's challenging. 51% of employers interacting with the Americans with Disabilities Act when administering the FMLA indicated it was difficult or extremely difficult, and for a number of reasons. Is training supervisors and managers on the federal leave laws, managing intermittent leave, controlling employee abuse of it, which oftentimes in managing leave, they're really just rubber stamping and approving all leaves, which can be costly, and then ensuring consistency of applying FMLA requirements across the organization. So for those multi-site employers, many employers struggle with it. It's difficult to keep up and interpret federal and state leave and disability legal requirements. Employers are finding that intermittent absences especially negatively impact productivity and morale. And employers lack really the staff resources to consistently and effectively manage leaves of absence and ADA issues. We had a client, roughly 3,000 employees. There are various locations across the country, so they had a number of different states in play. And it was, I think, a three-member employee benefits team in-house. And one of the individuals was spending roughly 80% of each week just addressing current, ongoing and new leaves. So it's becoming a priority for a lot of employers. And here, this graphic from Guardian happens to show, just based on size of employer over the years, how it's continuing to become more and more of a priority as the complexities around leave management increase year over year. So a little bit about the Family Medical Leave Act, the employers who are impacted. It's private employers with 50 more employees working each day during each of 20 or more calendar work weeks in the current or preceding year. Public agencies are covered employers without regard to the number of employees, and public as well as private elementary and secondary schools also covered without regard to the number of employees. So if an employer has 50 employees but no locations with 50 employees within a 75-mile radius, then none of the employees would be eligible to take the leave. So you have to have at least the 50 employees within the 75-mile radius. So eligible employees, those working for employers with 50 or more employees within 75 miles. Counting remote and telecommuters, work location is the office to which they report and not their homes. So you're evaluating the office that they're basically affiliated with as opposed to their actual remote work location. They have to have worked a minimum number of 12 months. They don't need to be consecutive, and have 1,250 hours in the year preceding the leave. 1,250 hours worked in the year preceding. The qualifying reasons for a leave, and it could be the employee's own serious health condition, the health condition of the child, the parent, spouse, qualifying exigency, or military caregiver as well. So some of the types of leave, there are really three main types of leave: continuous leave, a reduced schedule, or intermittent. And again, the intermittent are probably the most challenging for employers to manage, just because it can be taken on an unpredictable and periodic basis. So there was a recent DOL opinion letter in regard to leave, FMLA leave, and we have it highlighted here. According to the DOL's opinion, employers cannot delay designating an employee's absence as FMLA leave, even when the employee is using paid leave and doesn't request FMLA leave. So it's just an additional administrative challenge for employers really to have to adhere to. And the absence, as they say here, must count against the employee's annual FMLA leave entitlement. So again, the challenging law to really administer, and it's just continuing to get more and more challenging. And again, here you can see many states are implementing their own leave laws as well. So the FMLA leave itself is challenging enough, but then when you throw in multiple state-specific leave laws, it can just get overwhelming, which is why that one client I referenced had the one individual focusing almost 80% of their time just administering and managing the leaves. So the color coding here, the red are states with fewer than 5 different leave laws. The gold is 5 to 8 different leave laws, and then the blue is 9 or more leave laws. So California and New York are definitely two of the more complex states out there, New Jersey as well. So it can be costly, obviously, not only just from the loss of productivity, but it can be costly for employers if they're inaccurately administering leaves. And this slide here is just sort of highlighting some of the recent settlements: 9.8 million, 2 million, 1.15 million, almost 12 million against Advocate Health for violating FMLA. So it's not really anything to mess around with. The penalties here, the settlements can be very expensive, not to mention the legal fees associated with it as well. And it's really just, you can imagine how complex if you're especially dealing with multiple states and multiple locations. So employers really consider outsourcing so they can simplify the disability and absence administration, reducing the workload of their staff internally and relieving the burden on their HR staff, and then removing liability as well, reducing the total cost of the absence, so really being more efficient about the management of the leaves, and then ensuring compliance with increasingly complex regulatory and legal requirements. So, and then at the end of the day, for the employees as well, generally, it's a much better end-to-end experience when employers utilize a firm that's focused on exclusively administering and managing their leave. Some of the additional benefits of outsourcing, there's call-in procedures. So courts have actually found in favor of employers on FMLA claims because the employee did not properly notify both the employer and the outsourced absence management provider. So when there's some skin in the game for the employee as well, it can help eliminate some of that liability for the employer. It can be especially helpful in managing intermittent leave, as we said, because they're more complex. And then outsourced medical information, benefits an HR managers not having access to certain medical information and avoiding any HIPAA issues and access to information that they really don't need to or want to have access to. So this next slide, I'm just highlighting here some of the recent webinars that we've had with some of our partners, Sun Life, and also the folks at Guardian and others planned in the future. They're really just trying to keep folks informed and aware of different changes and trends in the marketplace, especially in regard to leave management. We have a ton of resources available, so if anyone has questions on any of the leave-related subjects we touched on here today, or really any of the subjects, we're happy to share that with you. Please feel free to reach out and contact us. We have our information noted here, and this presentation is actually going to be available via recording as well. So if you wanted to reach out to us at that email address there, it's my email address, or info@benefitsqb, and we'll be happy to provide a link so you can access this recording at a future date. So with that, I want to thank everyone for their time this afternoon. I appreciate it, and we look forward to speaking with you again soon. Take care.